primarily in kids. She does work at both SFU as well as BC Children's Hospital. And her talk is going to be about the psychological predictors of concussion recovery, translating knowledge into impact.
Thank you, Randy. All right, so thanks everyone so much for being here. My name is Cairncross, and I am an assistant professor in the Department of Psychology at Fraser University. And by training, I'm a clinical neuropsychologist, which essentially means I'm a clinical psychologist with specialized training in brain injury, helping people understand the impact of brain injury on emotional, cognitive, and behavioral aspects of functioning, and helping people know what to expect when they're recovering. So as a neuropsychologist, working with folks with concussion all the way up to very severe TBI, I've always been really interested in understanding from the perspective of concussion, why is it that some people recover rather quickly from a concussion, some people in days, a week or two, but for others, they continue to have symptoms for weeks, months, sometimes even years after injury. So today I'm going to be talking about some research on some of the psychological predictors of concussion recovery and how we can use this knowledge to actually create interventions that are effective for helping patients cope with persisting post-concussion symptoms. So just a brief overview of where we're going today. I'll talk a little bit about concussion just for folks who aren't as familiar, then move on to talking about some of those psychological predictors of concussion recovery and how we can translate this into clinical impact. So a concussion is a type of traumatic brain injury. It is an acute physiological disruption of brain functioning that's caused by some sort of external force to the brain. So it might occur when your head hits an object that's stationary, when an object hits your head, but it can also occur through whiplash type injuries where the brain is moving back and forth inside the skull. These types of injuries, they cause changes at a cellular level. We don't typically see structural changes on our sort of typical CT MRIs that you would get in clinical care. Some people do experience things like contusions or bleeds from small blood vessels breaking, but this is a little bit less common. So most people don't experience that level of damage. But the acute physiological changes that we see are what cause what we call post-concussion symptoms, which are actually quite variable. They're quite heterogeneous and quite non-specific to concussion. So the most common symptoms experienced acutely after concussion are things like fatigue, headache, changes in sleep, emotional changes like irritability. I'm sure some of these sound familiar. We all get headaches every once in a while. We all get fatigued and irritable. And so those are some of the most common, but they're quite variable. Most people will recover fairly quickly from concussion, some in a couple of days, some in a couple of weeks. But there is a sizable minority of individuals who continue to experience symptoms that last longer than a month after their injury, which this is the time frame where we would typically call these persisting post-concussion symptoms. Even though this is a smaller group of individuals, it's an incredibly important group for us to understand because even though we sometimes call these mild traumatic brain injuries, it can seem anything but mild for these folks. So when they continue to have these symptoms that last longer than a month, they report significant reductions in their overall quality of life, difficulty with work or going back to school, changes in their ability to socialize with friends and family, and significant mental health concerns. So understanding why some people have this slower recovery is really, really important. So some of the things that we assume might be related to concussion recovery aren't actually the best predictors. So you might expect things like loss of consciousness to be a good predictor of how long it might take someone to recover, right? If you get hit hard enough to get knocked out, you might think that person might have a little bit of a longer recovery time than someone who doesn't get knocked out. But research shows that that's actually not the best predictor of concussion recovery. And some of the most important predictors we have are things like pre-injury mental health status, so having depression or anxiety before your injury, and acute post-injury distress, anxiety, depression, trauma. Those tend to be actually our best known predictors of long-term concussion outcomes. And today I want to highlight a couple of behavioral and cognitive processes that seem particularly relevant for how people cope with their concussion symptoms and how people think about their concussion symptoms, which seem particularly important for some folks that have these persisting post-concussion symptoms. So much of this work was done at the Coping with Neurological Symptoms Lab at UBC, led by Dr. Noah Silverberg. So I'm going to review some of that literature and then talk about some of the work that we're doing in my lab at SFU. So I want to highlight a couple of cognitive and behavioral processes that seem critical. So one is fear avoidance behavior. This is a coping strategy that actually emerged from the chronic pain literature. So it helps to explain why some people go on to experience chronic pain after they've had some sort of acute musculoskeletal injury. And what this sort of theory posits is that people who have some sort of injury, then they have a pain experience. If they have catastrophic thinking about that pain, so this pain means that, for example, if I have low back pain, the more pain I have, the more likely my spine is continuing to be damaged. Those catastrophic beliefs about pain will lead someone to fear things that might bring on that pain. And if we are worried about pain and fear those things, it makes a lot of sense that we would avoid doing things that might activate that pain. And the more you avoid doing those things, it increases your chance of getting things like disuse syndrome from not using the body part that's injured, increased disability, and depression. And this model is a really good way to understand how someone goes from acute to chronic pain. And Dr. Silverberg has applied this to concussion. And so I'm going to talk a little bit about what this looks like in concussion. So as an example, if after you've had a concussion, bright lights are really distressing to you, they maybe give you a headache. That's pretty common. We hear that a lot. If you take a lot of care to avoid those bright lights because you're worried that if you expose yourself to bright lights, you'll get a headache, and maybe that headache means that my brain is being further damaged or I'm never going to recover from my concussion, it makes a lot of sense that you're probably going to try and avoid situations that are going to expose you to bright lights. But that might mean avoiding things like parties or going to the mall or going to the grocery store, which can lead to significant impairment in day-to-day functioning and depression if you're not able to do those things that you typically have to do or want to do. And so we have looked at what is this trajectory of fear avoidance behavior in people with post-concussion symptoms. So this is a prospective cohort study of 84 adults. We assessed them at concussion clinic intake, which was about 40 days post-injury, and then again at 1 and 3 months. This graph has the fear avoidance behavior on the y-axis, and each dot is an individual patient. And this shows how their fear avoidance behavior changed from clinic intake to 1 month follow-up. So you can see there's a group of individuals on the left who show reductions of their fear avoidance behavior over that 1 month period. It's pretty natural and makes a lot of sense to acutely after a concussion avoid some things that bring on symptoms. It's good to rest. You don't want to push it too hard. So that makes a lot of sense. And then you'll see a reduction in that avoidance behavior. But on the right-hand side, we have a group of individuals who show increased avoidance behavior. And these are the people we're a little bit more worried about. And what we see is that over that 1 month period, even when we control for post-concussion symptom severity, fear avoidance at clinic intake and increases in fear avoidance behavior over time from clinic intake to 1 month is uniquely predictive of disability in individuals with post-concussion symptoms. So you can see that there. I also want to highlight an important cognitive thinking style, which is also acknowledged in this fear avoidance model of concussion, and that is catastrophizing. Catastrophizing is a type of repetitive, sort of negative thinking style, commonly referred to as rumination. People are probably familiar with that, right? When you sort of think about something over and over again. Catastrophizing is a very specific belief related to that, in that someone fixates or thinks about the very worst possible outcome that could happen and treats that as the most likely outcome. So an example in concussion, someone might have sort of catastrophic beliefs about their headaches, which I mentioned, right? That means my brain is being damaged. It means I won't recover. And we wanted to know whether those catastrophic thinking styles mediate the relationship between post-concussion symptom severity and that fear avoidance behavior, which is what is posited in that chronic pain literature. And so in that sample of 84 adults, we looked at this relationship, and we did in fact find a significant indirect effect of post-concussion symptoms on avoidance behavior through these catastrophic beliefs about concussion symptoms. A couple of other psychological factors that I've researched are things like pessimistic attitudes about recovery. So pessimistic attitudes about recovery are associated with significant emotional distress after injury and predicted emotional distress above and beyond actual symptoms. And I've also done some work looking at how trait mindfulness is associated with patient-centered outcomes like quality of life after injury, and found that even adults who have prolonged recovery have high symptoms, high disability. Those who report having higher trait mindfulness actually report better quality of life than folks who have lower trait mindfulness. So this research highlights this importance of psychological resilience, ability to cope, how we think about symptoms in concussion. And this is actually reflected in our clinical practice guidelines. So this is from the Ontario Neurotrauma Foundation. And they suggest this hierarchical approach to symptom management, where we first start with managing things like depression, anxiety, irritability, sleep disorders, and post-traumatic headache, with this idea that if we can treat mental health complications and sleep problems, those are likely to perpetuate these other non-specific MTBI or concussion symptoms like cognitive impairment and fatigue. So if we can address those symptoms first, we might actually see improvements in other symptom domains. And so I propose taking this sort of transdiagnostic approach to concussion and concussion care. So we know that concussion symptoms are highly nonspecific, they're highly heterogeneous, they span a number of diagnostic boundaries like anxiety and depression, post-traumatic stress disorder, chronic pain, lots and lots of overlapping symptoms. So this is a image from Dr. Grant Iverson's paper that was published in 2019, which suggests we sort of take this network approach to symptoms, right? The symptoms of concussion are likely to co-occur because they're interrelated and they're mutually reinforcing of each other and they amplify each other. And it's not likely that they necessarily come from this latent disease entity. And in clinical practice, distinguishing the effects between depression and anxiety and post-concussion symptoms is actually very challenging because there's some substantial symptom overlap. So I propose taking what's called this transdiagnostic psychological processes into account. These are processes that underlie a number of psychological conditions that are likely to perpetuate and maintain symptoms over time, as well as those interconnected symptom clusters. And one promising treatment approach is mindfulness. So mindfulness-based interventions are effective for treating a very wide range of complex health concerns. And there's been some evidence to suggest that they might have positive impacts on people across the spectrum of TBI severity. But there is a couple of problems with mindfulness-based interventions generally that I'm sort of trying to highlight within my work and address within my work. And one is accessibility. So just like most mental health services, they aren't accessible to most people. They're expensive. They require you to be in person. Typically, especially for concussion care, it's in like a urban city center, where we actually see most people, the highest proportion of concussion are rural communities. So we're not really servicing people with concussion effectively if we make people come to our city centers for concussion care. These interventions are often developed without patient inclusion, which we know can actually increase uptake by patients if we know that it's what they want and what they need. And a lot of this research focuses on, can we make post-concussion symptoms go away? And I sort of take a different approach in that, how can we help you cope more effectively, with the hope that if we can cope a little bit more effectively, you can get back to your valued activities, and down the road, eventually those symptoms, because they're so interconnected and amplifying, they will reduce over time as well. So with a group of collaborators at CHIO and the University of British Columbia and our industry partner, Mobio Interactive, we have developed a mindfulness-based intervention app that's delivered over a smartphone app for concussion recovery. This will increase access for patients and help people cope with their symptoms more effectively and return to their valued activities. So we did a very small pilot of 10 adolescents who had a concussion. Either this was acute and we had patients with sort of chronic and persisting symptoms, and we gave them the intervention for 4 weeks. And at the end of the 4 weeks, we asked them some questions about, is this intervention credible to you? Does it seem like it would help? Were you satisfied with the treatment you received? And was the app usable? Overall, patients reported as credible. They were satisfied with the care that they got, and the usability was average, definitely some room for improvement. And we got a lot of great qualitative data doing semi-structured interviews at the end of the intervention. Patients loved that it was accessible. They loved that they could pick up their phone and use it at any time. They loved the meditation guides who brought them through the mindfulness intervention and gave us some excellent recommendations for improving our intervention. And I have a fantastic graduate student, Caitlin, who is working on this intervention for adults as well. So just wrap up some key takeaways, because I know I'm short on time here. Psychological factors are, right now, our best predictors of concussion recovery. Transdiagnostic processes like behavioral avoidance and repetitive negative thinking prolong recovery and lead to higher disability. And if we can use psychological treatment to target these transdiagnostic factors, this addresses that heterogeneous nature of concussion symptoms and will be likely critical for improving outcomes. So thank you very much.
Wonderful. Thank you, Molly.
Thanks.
One question I have, and I'll turn it over to the rest of the audience. I have the mic again, so I can hear this. One thing you didn't mention was differences having to do with sex, and
Yes.
differences having to do with things like either culture or socioeconomic status.
Yes, yeah, great question. And in terms of outcomes or intervention work, or maybe a little bit of both. So we do see some sex differences in recovery. Typically what we see is girls and women tend to have a little bit of a longer recovery time. Now, we don't know exactly why that is. There's some hypotheses around physiology and neck strength. So it's possible that women and girls tend to have lower neck strength, and so they're more vulnerable to concussion. There's also some sort of socio-cultural bias in our reporting as well. So women might be more likely to report some of these post-concussion symptoms like irritability, depression, and anxiety, and men may be less forthcoming with those. And so I think it's a little bit of both, probably a little bit of biological and also socio-cultural changes there. And I think with psychological interventions, one thing I'm interested in seeing is there a different uptake based on gender? So we know specifically for mindfulness-based interventions, they tend to be much more heavily used by women who are white and who have high socioeconomic status. So that is a major limitation right now of some of the mindfulness-based intervention work. And so we hope by offering it through smartphone-based apps, we can catch more people who aren't necessarily getting access to that kind of treatment. One of the nice things about our industry partner is that they've basically developed the app so that you can download all the content and you can use the content in a place where you don't necessarily need Wi-Fi or connection. So we hope that will help even further with folks who live in rural areas who may not have great Wi-Fi. They can still, you know, when they're in the city and if they're told to use this app, they could download all of that and use it at home without the need for Wi-Fi connection. So certainly still going to be some disparities, but I think this is a good first step. Yeah.
I'm wondering, I've done some work. Turn on the mic. Now it works. Okay. So I'm wondering if there's any, I've done some work around mindfulness, and one of the most consistent features about mindfulness interventions that they're most effective when they happen in a social context.
Yes.
So people just don't mindfulness meditate, but they get together with others on a regular basis that they get to know, and they can expect that social component of it.
Yep.
And so my question for you is, given that the TBI is medically assessed, is there anything that could be done or is already being done that can have some centralized database that connects people with TBI who may want to do mindfulness together? Some of them may not even have Wi-Fi access, but they might be able to travel. And so some kind of like almost like a support group for mindfulness meditation. Is that something that exists? Or if not, are you thinking about doing something like that?
Yeah, such a great question. And we think about that a lot because we know, part of the intervention is usually it's in a group, in person. And so you can share your experience doing the meditations. And one thing we hear so often is, oh, I'm so bad at mindfulness. I can't get my mind to go blank. And that's sort of what people think mindfulness is. And so when you're in that group setting, you get that feedback. They're like, no, I had difficulty. So did I. And we're having the same challenges. So that probably is an important piece. However, there is a lot of research that shows that the mindfulness apps that don't have that social support have pretty close effect sizes to in-person mindfulness. So it doesn't appear like it's necessarily necessary, but that is something that we've talked about. We have a patient partner working group for the development of our adult intervention. That was one of the things they brought up, well, when I did mindfulness, it was nice to have that connection. So I think once we start moving towards our feasibility and efficacy trials, that might be something we consider including, like even maybe some kind of like remote chat where people who are doing the intervention at the same time can have some sort of social support. But I think that's a great point. Yeah, thank you.
Question.
Okay, hi.
Hi.
Great, thank you. So one small thing, do you know why specifically concussions are more common in rural areas? And also with the fact that you said that it's the whole reason for the app is that access to like professional mindfulness help is inaccessible. Is there anything that can be done with the app, but like a family member is also helping? So there's like a guided, I don't know, some sort of like instructions of getting kind of closer to like an in-person from professional help. Yeah,
two great questions. Thank you. So the first one around why is prevalence higher in rural areas? One, the type of work that they're doing, they're more likely to experience concussions in the workplace, as well as different like recreational activities. So it's interesting when you work in sort of different cities clinically, you'll see the TBIs you're seeing tend to be for different reasons. So when I worked in Detroit, Michigan, we saw a lot of motor vehicle accidents, a lot of assault. When I worked in Edmonton, it was like moose versus car, you just, you see these very different types of accidents depending on where you are. So that's the reason for sort of higher incidence in more rural areas is recreation and work. And then your second question was, remind me, sorry. Right. Yes. Yeah. Another great point. So that's one of the other things we're considering, especially for the adolescent app, is my sort of dream. Once I have a little bit, of a bigger lab, hopefully, is to get someone to create a parent sort of mindfulness intervention that goes along with the adolescent so that they can be practicing together. Because we know people who work with adolescents and kids probably know getting the parents buy-in is also really important for treatment. And that's a lot of typically when we're doing psychological interventions, there is some involvement with parents. So I think ideally we'd create some sort of parent or caregiver option, which could be the option for adults too, if they wanted to. But they're always welcome to sort of practice with families as well. It's all audio guided for the most part. So you could just put it on your app, turn the volume up, and in theory, you could practice with others, which might be helpful. Yeah.
We'll go to the cloud house. Questions from Zoom.
We have a few questions from Zoom. I'll read the first one from Kyle Berg. Could you speak a bit more on the relationship between neck strength and concussion?
I couldn't. No. That's a yeah. I would say people who do sort of sport concussion, specifically physiotherapists, are at a much better place to speak on that. All I know is that is an area right now that researchers and clinicians are interested in, because that might be one of the reasons that helps explain why girls and women tend to report more severe concussion symptoms over time. But that's sort of the extent of my knowledge. Sorry, Kyle.
All right, from Bryce Phillips. Do you think that athletes who suffer from repeated MTBIs have greater fear avoidance and catastrophizing tendencies are at a greater risk for developing CTE?
Good question. And there would be a lot to unpack there. I'll just say, I mean, we know in the case where we're talking about like one uncomplicated MTBI or a couple concussions over a lifetime history, especially when they're not back to back, right? When concussions happen before you've healed, we don't want that. That's not good. For folks who have sort of repetitive concussions, for like the elite athletes who are also having subconcussive hits over and over, it likely could. I don't know if it necessarily would at like a biological level, but certainly like we know some of the symptoms of people who experience CTE are mood changes, depression, changes in functioning. And we know that fear avoidance behavior and catastrophizing can amplify that depression and changes in mood and changes in functioning. So I don't know that it would necessarily cause CTE, but it certainly could amplify those symptoms over time, I think.
All right, the last one is actually a comment from one of our Zoom participants, Susan Fitzpatrick. Says there is some studies coming from the US Brain Trauma Foundation that attentional disturbances can contribute to multiple mild concussive injuries. So a prior brain injury can contribute to subsequent brain injuries.
Yeah, great comment. Absolutely. So changes in attention, absolutely, which is one of the reasons I actually, one of my grad students is studying for their master's thesis, attentional bias after concussion. So are we more likely to sort of attend to our sort of physical somatic pain symptoms and those negative symptoms more often if we have those persisting post-concussion symptoms? So attention is certainly something to look out for. The research is a little bit mixed in terms of the neurobiology, but typically what we would see is sort of frontolimbic dysfunction in some folks. So that could certainly be associated with those differences in attention.
Hi, that was a really interesting talk.
Thanks.
I'm really curious to hear a little bit more about the avoidance symptoms. So I have a two-part question. One is, you mentioned that the avoidance tends to be tied to avoidance of symptoms. So being put in situations where symptoms might be perpetuated.
Mhm.
I was wondering if that avoidance extends to putting one in situations where they would sustain another concussion.
Yes.
And the reason I'm asking is because I studied memory, and I was wondering if you could unpack or speak to the relationship between avoidance behaviors and intrusive memories, both for either pain or other symptom related situations that have occurred post concussion, as well as intrusiveness for the original memory that caused the TBI.
Yes, yeah, absolutely. Great question. And to answer, yes. So the fear avoidance is associated with avoidance of sort of symptoms broadly, avoidance of activities that we think might bring on symptoms or worsen symptoms, but also certainly within that is avoidance of activities that might put us at higher risk of experiencing a concussion. So like one of the interesting things that's coming out right now in the sports literature is rather than just focusing on physical return, so when are you physically ready, the actual psychological readiness to return to sport, which we actually don't really know that much about, but hypothesizing one of the things is like, I'm scared I'm going to get another concussion when I return to sport. And so that might lead people to avoid doing things that before, like, especially with sports, that's your community. It's usually where you're spending lots of time. You have lots of friends and support that way. But if you're worried about getting another concussion, you're likely to avoid doing those things. And we know that can lead to anxiety or depression and complicate recovery further. And I think you're right to tie in memory there. So memory and memory bias is another one of those sort of transdiagnostic processes that is likely to underpin a lot of psychopathology. And I think probably concussion as well. So having sort of memories or things, you know, your mind is going to when you had your injury, or maybe the last time you went for a run and you felt really crappy after, you had a really bad headache. And so those memories might reinforce that fear avoidance behavior as well. Yeah, great question.
Hi, can you hear me?
Yes.
Okay, so my question was, have you thought about including artificial intelligence as a feature in your app?
Maybe. So our industry partner has some cool features. I'm not I mean, I guess I don't know if they would be defined as artificial intelligence, but perhaps. So they have something called a snapshot, where essentially you sort of take a picture of yourself and it sort of reads your heart rate variability in a sense by looking at sort of your skin conductance and your blood in your face, and ask you to report on your subjective stress before and after your meditation practices. So it essentially tries to give you sort of like a biological readout of your stress as well. Interesting features. I'm hoping to do a little bit of work on that, how that looks, whether that correlates with the subjective experience of our patients using the app. But that is largely controlled by our industry partner. But yeah, I think they're hoping to do a little bit more of that sort of clinician, specialized care and make recommendations about what meditations you should try based on those sort of like biological predictors. But yeah, always something to think about. Thanks.
Hi, sorry. So I'm wondering if the app is live for the public, and if yes, what is it called?
Yes, so the app itself is, it is called DTX AM. It's available for download, but the actual concussion intervention is not yet live. So our concussion intervention is only available to participants in our trials until we determine that it is safe and effective. So we'll be running some feasibility trials in the next couple of years, and hopefully efficacy trials as well. And then hopefully it'll be accessible to the public once that's done.
Just went. I'll give it back to you from that. One question in terms of sort of future prospects. Obviously, having an app that can be used anywhere is quite helpful, especially for remote communities as well. Could you talk about some of the things you might want to take into consideration as you move to the older age groups, for example, where there's sometimes concomitant issues, for example, cognitive impairment from dementia, or potentially after head trauma, or just head trauma in general on older people?
Yes, yeah. So some of the things that we definitely want to take into consideration is just the usability of the app. So like one of the things we've been doing, as I mentioned with my trainee, Caitlin, her PhD dissertation is on developing this app for adults. And we have a 3-person working group of patient partners, people who have lived experience of concussion, had mental health problems after their concussion, and are sort of helping us develop the app. And so we actually gave them the app prototype to adolescents and had them walk through the app, and we did sort of cognitive interviewing with them, asking them like, okay, you know, which button would you go to next? Does this seem intuitive? And they had some excellent feedback, like, you know, these buttons are very confusing, change this, change the sort of structure. And so that's one of the things we've been doing to ensure that it's more accessible for older adults. In terms of cognitive impairment, there has been some research looking at mindfulness-based interventions for people with moderate to severe TBI. I think it would be harder in that population, especially self-guided. So I wouldn't necessarily see this as an intervention that would be necessarily appropriate to someone with severe cognitive impairment. So this would be more likely a supportive intervention for people that have concussion, you know, not super complicated, you know, multiple repetitive concussions, and, you know, maybe cognitive impairment on top of that from a neurodegenerative disorder might not necessarily be appropriate for that group. But yeah, something to consider, absolutely.
Do you know about any work being done that's what you say, a guidance or mindfulness intervention for people who have cognitive impairment like dementia?
I believe there is some research. I don't know the efficacy of it off the top of my head, but I know that it has been done. I know there's a group actually at Harvard who is doing the interventions like with caregivers. So I think having that caregiver piece would be really helpful when there's cognitive impairment like that. Doing, especially with self-guided, like being able to self-guide through an intervention would be challenging depending on the level of cognitive impairment. Yeah.
Hi, one more question for me. Just thinking about some of the questions that came up in the keynote, I'm just wondering about like broadening out from the psychological to the neurological and the interface between the two. So I know you focus a lot on psychological factors, and my understanding of some of the discussion earlier in your talk and my own take on the literature is that the neural signatures of concussion or mild TBI are more subtle and sometimes only detectable with certain kinds of neuroimaging techniques. I'm just wondering your broad take on where we go as a field in terms of linking the psychological and the neurological for a more holistic understanding of mild TBI and the predictors of recovery.
Yeah, great question. And you're right on the literature. So we typically can't see structural damage on like our traditional imaging, like CT scans. And in some cases, you'll see it on more sensitive, like DTI. Interestingly, my colleague, Dr. Andréane Ledoux, who is running the she's running this study, the mindfulness intervention app in adolescents acutely after concussion. So she's recruiting people 48 hours after injury and enrolling them in the app. And at CHIO, they are actually running a small subset of those folks will get a functional MRI scan pre and post the intervention to look at whether there is actually sort of a biological mechanism that's that correlates with our subjective outcomes. I won't necessarily be doing that here unless I find someone who's really keen to do that with me, because that is certainly not my area of expertise. I'm more on the patient perspective side. What you tell me is what I study, but I think it's really interesting to combine those two things. So it'll be interesting to see what they find there at CHIO. Yeah.
My comment was I'm actually working with Noah Silverberg.
Oh, great.
Yeah, so we're actually part of his grant. We are doing functional MRI, and so we've collected about 60 scans so far, and we have another 10, maybe. Yeah, we're going up to 75 scans of patients who have had a concussion and are experiencing symptoms of FCD versus. Yeah, so that is something that's here, just letting you know. And what was the name of your collaborator or the person at CHIO?
Dr. Andréane Ledoux.
Okay, I will try and spell that.
Yeah, Ledoux.
Last question.
Hi.
Hi.
I'm just curious, you mentioned sort of chronic pain components earlier. If there's any intersection between migraine and concussion, thinking about people with a history of migraine, so head pain that's not concussion based, is there any kind of intersection there that relates to treatment and outcomes and liability, things like that?
Yeah, there is. That's a great question. So typically, like pre-injury mental health, but also pre-injury physical health is also a really good predictor of outcomes. So typically people that have some sort of migraine disorder before their injury are likely to have exacerbations of that after concussion. So that is one of the risk factors as well for post-traumatic headache if you've already had some sort of headache disorder, which is, we don't necessarily have great treatments for all of those headache disorders either. We don't really understand exactly what causes all those different types of migraines. So mindfulness has actually been a treatment that's used, was originally sort of secularized to use in individuals who have chronic pain and things like migraine to help them. It's not necessarily, we're not going to make the headache go away or the pain go away. What we're going to do is help you still do the things that bring you joy despite the fact that you have this pain. So I think that's why this is an interesting treatment approach for concussion, because like we said, it has overlap with things like chronic pain and migraine disorders as well.
Great, thanks, Ben. And thank you, Molly. Again, it was a great
Thank you.
presentation and great discussion session. Thank you, Molly.
Thanks, everyone.